Good afternoon and good evening, everyone. Welcome to the fundraiser webinar on behalf of the New York Society of Interventional Pain Physicians, Stories of Heroism from the Frontline Fighters of the COVID Crisis. We are so happy you have joined us this evening. The call will start in 1 minute to allow a few more attendees to log on. Again, thank you for joining us this afternoon, and we will begin in 1 minute. Good afternoon and good evening, everyone. Thank you for joining the New York Society of Interventional Pain Physicians for a fundraiser webinar. This one will focus on stories of heroism from the frontline fighters of the COVID crisis. We are so happy that you've joined us this evening and really appreciate your time. I would like to introduce I have a few webinar tips for everybody tonight. We sincerely want this webinar to be interactive, and we look forward to your questions. If you would like to ask a question, please do so in the chat box. We will forward those questions on to our moderators. Please keep your questions succinct, and if you would like to specifically have one of the moderators or speakers address your question, please make sure that is clear at the beginning. We will attempt to answer all questions as time allows. I would like to introduce our moderator, Dr. Sudhir Dewan. Dr. Dewan is the president of Advanced Spine on Park Avenue. Dr. Dewan is nationally and internationally recognized as a key opinion leader in the field of interventional pain management. He is the immediate past president of ACIP and the founder and chairman of NYSIPP and the New York, New Jersey Pain Symposium. Dr. Dewan, take it away.
Thank you, Michelle, for kind introduction. I'm so happy today because this is a webinar for a very special reason. We are here to salute those frontline heroes who have put their life before, they put their services before their life, and we have no words to appreciate that. I would like to start with thanking my executive board, who has worked tirelessly to make this fundraising webinar very successful, and especially who are not here on camera with us is Ken Chapman and Ed Rubin. Ken is our president-elect, and Ed Rubin is past president. They have worked tirelessly to, again, raise the fund. And also, I would like to appreciate services of Karina, who is frontline worker from Montefiore Hospital, who is the secretary of NYSIPP. With that, I'll start introducing our moderators today, and we are so fortunate to have all these gentlemen here. Tim Deere, who is world-renowned pain physician, I'm sure you all know. He's a founding chairman of the American Society of Pain and Neuroscience. Second moderator is Dr. Brian Durkin. Brian, Nick, if you can turn off your camera, the Brian can come on for a second. Brian is our current president of NYSIPP, and he is running the multiple centers, pain centers in Long Island. And our the moderator is Dr. Chris Garibo. Dr. Garibo is also a world-renowned pain physician. He's a professor in NYU, and he is a past president of NYSIPP and a very, very active. He's a course director of New York, New Jersey Pain Symposium. The next slide. These are the information. This slide you may see a few times. Those who want to donate by check, here is the make check payable to Ironman Foundation, and here is the address. And you can also donate online. If you have any question, you can reach out to Sandra. I want to introduce Sarah Hartman. Sarah is originally a New Yorker. She is the executive director of Ironman Foundation. She looks over all the activities of the charity work. She does fundraising drives and works with the board of directors very, very closely. Sarah.
Good evening, everyone. And thank you so much. Thank you so much for having me on the webinar this afternoon and for your support of Iron Aid. By way of background, the Ironman Foundation is the nonprofit arm of the Ironman Group and our family of around 250 endurance events worldwide. We are a 501c3 nonprofit organization, and it's our mission to create positive impact through grant funding and supporting volunteer efforts. Dr. Deere has been a long-time supporter of the Ironman Foundation. He's raced multiple times with us at the Ironman World Championship in Hawaii, and just last year he proposed that we launch a new program, which is now called Iron Aid, so that athletes in the medical profession could raise funds and awareness for health-related causes. And so this year, in the wake of the pandemic, the entire focus of the program, and frankly the Ironman Foundation, is Iron Aid COVID-19 Support Fund, where athletes, supporters, and donors just like you have helped us launch the support fund. I'm excited to say that just this week, we sent out our first round of grant funding. $100,000 went out to 40 different organizations. They are health-related organizations, and we're supporting their COVID-19 response programs. Of those 40 grants, 4 were awarded in New York State. And we were very pleased to present this rapid fire funding to meet immediate needs. Things like support the vulnerable, to replenish the food bank, and the like. Now, applications for the second round of grant funding are currently open, remain open until May 29th. So if you know an eligible organization, invite them to apply for an Iron Aid COVID-19 grant. That link to apply ironmanfoundation.org/ironaid, and it is also on the fundraising page. And we want to thank you again for your generosity. I did want to mention 2 of the sub-programs of Iron Aid. They are Operation Iron Aid face masks, where we are repurposing new unused race shirts into non-sterile face masks. Here's a visual. These are non-sterile face coverings, and we're also making acrylic face shields. A second program newly launched is called Operation Iron Aid Nutrition, working to replenish food banks and also frontline workers. I wanted to say thank you to Hall of Fame quarterback Jim Kelly for donating some great memorabilia. I think we have a slide that shows some of the gifts that he's provided for our Iron Aid drawing. $10 donation is 1 entry into the drawing, which ends at 12 p.m. Eastern Time on May 17th. So please enter. Thank you again for your generosity. Thank you, NYSIPP. Thank you to all the heroes that we're meeting tonight. As a born and raised New Yorker, I want to thank you for everything you're doing for my friends.
There was some audio problems with Sarah, but I think Dr. Deere can join us now.
Okay, Sudhir, thank you so much. Sarah, thank you for joining us, Sarah. And you know, your work around the world has been great. And as you know, the work you're going to do in New York State with this group is going to help a lot of New Yorkers. And I know New York's been considerably struck by this. And so Dr. Dewan and Brian, Kristen, the whole team, it's great that you're raising funds in New York to help those who are in need of healthcare and healthcare related things in New York. And, you know, in my experience, I've been raising money for different areas of charity for a number of years, but you know, we always race in my line of life. I've always raced for money. I've actually ran or biked or swam, but now I see people like, you know, Nick Bremer, who'll be with us tonight, and Paul Lynch, 2 good friends of mine, 2 young men who have a lot going on in the pain world, both decided to leave their practices and come to New York City and work at Bellevue in the ICU. It's that type of giving back that I just admire so much. And I think these 2 guys and many like them are amazingly heroes. Many of us like me, I really can't do that. So I actually try to do good work in other ways. And Iron Aid really allows us to do that. And the money that you're raising tonight is going to go to New York State to needs. And one of the things Sarah said, if you couldn't hear her real well, if you have some charities on the ground there who are in need of helping. For example, in Arizona, they help firefighters with PPE masks and things that they didn't have enough masks. So if you have a charity on the ground anywhere in New York State, please let us know ASAP. And you can send me an email, send Sarah an email, send Sudhir an email, and we're going to try to get any money raised tonight on the ground in New York State, helping those that you're working with. So with that, I want to say thanks for having me tonight to join you, Sudhir, and thank you for all the things you're doing to help others. And I'll give the panel back to Dr. Dewan at this point.
Thank you so much, Tim. You've been wonderful. Your help and your support is unbelievable. So now we're going to start the panel. The first panel and first speaker is Dr. Bushra Mina. I have a personal pleasure to work with him. He's such a wonderful human being. He is an associate professor of pulmonary care, and he's in ICU. He had a first-hand experience of COVID crisis, and we would love to hear from Dr. Mina. Go ahead, Dr. Mina.
Hi, good afternoon, good evening. Thank you very much for allowing me to participate in this wonderful function that you're raising money to help others and getting ready for hopefully for the next winter, and if there's going to be any surge. I think I had the opportunity to be on call the weekend. We had our first patient coming to Lenox Hill, and it was in the beginning of March. We know that the COVID-19 is coming to our area, but we didn't know when or how, or, there was a system-wide preparation at the system to be prepared, infrastructures and dynamics to get ready for this crisis. But when you go back to your home, an individual institution, or your ICU unit, we got the first patient, and I wasn't called. And at this point in the early, we heard some review articles, some news from China, a little news from Italy. We didn't have that information that we have now. We didn't have the literature, although it's inconclusive sometimes, but we didn't have anything at that time in the beginning of March. So it's kind of like you're going for your exam. It just like, how the web can be very helpful. So you can just Google, you get some richer research, what are the protocols in China. So this was my first experience in the first week in March when we had our first case. And it was a kind of learning experience. I mean, being in practice for more than 25 years, I mean, running the fellowship program, you teach, you read the literature, but you find out yourself, you're back against the wall, you're learning. You're saying something I never experienced in my life before. I mean, I dealt with the anthrax case when it was at Lenox Hill, and, memory comes back, dealing with an anthrax case. You read about it in the textbooks, but hands-on. So it's about more than a decade, and you find yourself, you're still at the front line. You're learning, and you're trying to help the patient. And you call your administrator, you call the chief of infectious disease, and you can see we don't have any data. Of course, we don't have any data because this is a new disease, and what the Chinese did. So, we started developing our protocols, and in our protocol, we are maybe version 19, and this is how we learn from our experience, learn from others. Within Europe, we had webinars with people from Italy, and the goal is just how to help our patients, how to be put everything in the front, our effort, our knowledge, our experience, and try not to hurt them in the meantime. Even the guidelines that came, some of the guidelines of, it's weak evidence. So this is more turned to be an experience for us. In the meantime, trying to do the best for the patient and help what we learned from the patient that we treated this morning, heard the patient that we're going to be treating in the afternoon. And in a very short period of time, we had one patient, then a few days, no patient, and then it's kind of the gates opened. And then we went over closing our office, went to 24-hour a day, 7 days a week shifts, We did morning shifts and evening shifts and night shifts. So we went into 24 hours. I had the pleasure and had the honor to be doing the first 8 days a night. So I volunteered to take the 8 days a night, and I thought it was just basically being the senior person in the division. I want to give the, we have to work. We can be behind desks making protocols. We developed the protocols as a division. We worked as a division, and we made the schedules. Our fellowship, we pulled all the fellows from vacation, from electives, and we had 24 hours as physicians and the fellow. And also we had the pleasure to work as a one family, interventional cardiology, neurocritical care physicians, cardiologists, neurologists, anesthesiologists, all came in and became one part of our schedule. And, it was, not doing any night calls for 25, 28 years, going back to doing night calls. It just feeling young again and energetics and, up all night, admitting 16 patients, intubating 16 patients a night, working with the anesthesiologist and other ER attending. And there was no fear at this point. It's a new disease everywhere. Everyone was worried about getting infected. Our fear was, if I get infected and I can't do the first week of nights, we're going to be short. So taking every precautions, from gowning, the mask. I got somebody donated P100 for me. I thought I needed at that time more than anybody else. Basically, as we took care of ourselves because we could not afford have a shortage in the manpower. And this is our story is, and day after day, we got a little busier. We opened another. We took all ICUs in the hospital, became COVID ICUs. We built 2 more ICUs. We built a negative pressure room, 19 beds, and like within 2 or 3 days. The administrator was very supportive, and everybody from the people that cleaned the rooms, the people that delivered the food, to the nurses' aides, cleaning the patients, to the nurses, to the resident, everybody was as a one family. And they passed. We got tired. We were happy when our 1,000 patient walked at the hospital, and that turned to be the father of one of our staff in the office. And you can see, this is not my office in the background. Actually, it's the hospital library. Our office was taken by the hospital and became to be a patient ward. So we want your office in a flash of light. Take it. We moved all our belongings, and in one morning we moved everything, and our office became a hospital patient. So I say it's a learning experience for us, and I hope we don't have to experience again. How will we, from overnight, we change our structure from fellowship, division, office practice, rounding in the service, to doing 12-hour shifts, 7 days a week, how to take care of the patient, learn from what is there in the literature, come in with what you think best practice, and try to help the patient, and also how to protect yourself to not to have an empty gap. And I would say we only had very few of our faculty, including the fellows that got sick, and I think, and the fellows with even the 2 that got sick that was eager to come back and share the opportunity. So, to say is, we're happy when we had 1,000 discharged. We're happy with our experience with extubating patient and learning how to extubate the patient. And we're very different from any other patient we experience in our life. This is not your typical ARDS. This is not your typical, some massive PE that you have to deal with. And I would say, as life as an experience, we enjoyed it. We were happy to help people, even the people that we were not able to help. The family, with the phone calls with them every day, you get some patients' families still calling and said, we know you guys did our best for our family, and they died, but everybody tried to save them and keep them alive, FaceTiming with the phones, with the family in the rooms. And it was, the best gift you can give a family, to sit there and hear the voice of the family who will not come to the hospital. I would say also the cooperation and talking to your colleagues in New York, even in Europe, was very amazing. We have even a chat on WhatsApp with physicians that we know in Italy, Spain, Portugal, China, and learning their experience and know how we can help our patients during this time. And this is kind of my story at this point.
Dr. Mina, it's unbelievable. It's just listening your story, and as a person right there days and night 24/7, and your energy and your aspiration, your desire to help other patients and putting yourself at the risk, we have no words to describe that. So thank you. You and others who are on the panel, you all are a gift from God for us, because this is very unique experience for us. And I just have a very short question. What has it affected personally as a physician? What have you learned?
I will learn is that as long as we practice, we need to learn, and we need to talk to among our colleagues. I mean, now is like, for example, in New York, it's everybody's a health system. We went beyond that. We all professions, we all physicians. We learned that communication is important, learning from each other, working with each other, and learning is protecting the patient and doing the best for them, and learning that one of the most important thing is how supportive our family were.
This is very important, because when you are struggling and working, the family is always worried about you, and of course, spread of infection. So thank you, Dr. Mina. We have no words to describe and appreciate your work. Chris, you want to go ahead with the...
Absolutely. Yeah. Hello, everybody. Good afternoon. I have the privilege and honor of introducing Dr. Ann Marie Stillwell. I've known Ann Marie through our NYSIPP activities. We've interacted many times. She's been in practice in Staten Island for about a quarter of a century, about 25 years. She's anesthesia-based, and she recently decided to update her anesthesia experience by helping COVID patients in her local area, and we're grateful to her for that. And she's here to tell us her story.
Thank you very much for inviting me here today. I had been in contact with Dr. Dewan, letting him know what was going on because we had trained in the same place together. And I too knew that this was coming sooner than most, because my husband works in supply chain for a major corporation, and he's been working from home for years. And I heard him say in the kitchen one day in January, there's going to be an interruption in supply chain because they've closed down all of the factories in China. We're not sure how long it's going to last, but they've got some virus going on over there. And that made me start, looking into this virus and what was happening. And before I knew it, I had a year's supply of toilet paper in my office basement, a year's supply of paper towels. I ordered all my procedures and kits and PPE, and was telling my patients, you should go out and shop, because I think there's going to be an epidemic coming our way. And this was before we even had a person here in New York, just from what I was hearing and researching. So with that, my own instinct was starting to get to me, and I started texting my family and following this. Some of my patients and family thought I was nuts, and they were expressing that to me in text. So as this started to become a reality, even to the point where I said, I can't believe this is serious. And then all of a sudden, about face and all the schools were being closed and the hospitals were really revving up. I went back to the anesthesia department where I had given anesthesia a few years ago, and I asked some of my colleagues on a Sunday morning. I said, could you show me how to use the ventilator again in the OR and show me how to hook it up to 2 patients? Sure, come on in, in case we need you. And that's what I thought I would be doing, filling in, going to the local hospital. But instead, just the last week of March, I actually consult for the Department of Health in the Department of Office of Professional Medical Conduct. And I received a phone call from the head. And he said, would you mind going and being a medical coordinator at the Javits, where, we need to have a station of the Department of Health at the Javits. So at that point, I said, well, is there anybody else? I really want to stay local for my own, my own hospital. And he says, well, most of the doctors who consult are over the Javits. So I said, all right, how long do I need to go for? And, oh, probably just a week. And we just want you to answer a few phones. It's really not going to be taxing. So I said, okay. I said, I'm not doing that much in my office. I started doing televisits. So I said, okay, I'll go answer a few phones. So that's all I thought it was, answering a few phones. Well, when I walked in the first day, which we hadn't even started taking patients yet, it was a sea of fatigues. Something I've never seen before, just a whole network of Army and Navy and National Health Service, all very active in a massive room, the top floor of the Javits. Even just walking in when I first got there, it was a line. Everyone was 6 feet apart. You had to have your temperature taken. They asked you the same questions every day. Very rapidly, very sternly, have you been exposed to the coronavirus and do you have a fever, ma'am? And it would be no. Do you feel sick, ma'am? And it'd be no. Okay, you can go, and then I would walk in with all these GIs and be, all right, what am I doing here? But they ended up taking me under their wing and showing me what our mission was, which originally our mission was to treat non-COVID patients in the city and take from all the hospitals. So I got right to work calling my local hospitals and calling the heads of hospitals and saying, listen, what patients do you have? We'll take them. I had to figure out, along with someone from the head of the National Health Service, how to use FEMA. FEMA would go and get an ambulance anywhere that I wanted them. And I would have to tell the doctors what I needed their patients to have available so that we could come and take them from their hands. Because the whole point of the mission was to decompress the hospitals, so that because they were going to start seeing a surge of patients, a surge which originally we weren't really believing. It was kind of surreal that this was going to happen. But then as the surge started to occur at the local hospitals, we were basically, by Thursday of that first week, we had basically taken 20 patients off of the hospitals. And we were saying, this is ridiculous. We have to switch to COVID. So just watching the news like everybody else was, on Thursday of that first week, it was the governor asking the president, can we now make it COVID, both the boat as well as the Javits? And we did. And Friday, they spent all day running oxygen lines through the entire Javits. And they had these massive machines that could make oxygen. And they had the ability now to deliver oxygen to every patient that was in it, because originally we didn't think we were going to need that much oxygen. It just got very, very busy to the point where, we were trying to get patients in, but the hospitals, when we would call, were too busy. They didn't have anyone free. As Dr. Mina was saying, there was just no one free to be able to give us patients, to tell us about the patients, to see if they satisfied the criteria which started out being very, very strict. They have to have had COVID for 14 days, had to be on less than 4 liters of oxygen. I mean, as I was speaking to the doctors at the hospitals, they just didn't have patients like that. I said, we're not going to be able to take anybody if we're going to be so strict with the criteria. So over time, I started relaxing the criteria myself and saying, okay, I'll take them. Okay, we'll take them. Because the Army was coming over saying, get us more patients. Like, what's happening here? We got all these docs downstairs. Get us more patients. So we ended up sending out doctors to the actual hospitals to look through their EMRs and be able to bring patients. And then by that time, we're getting to April 4th, April 5th, April 6th, April 7th. And we went from taking 10 patients the first day to 60 patients the second day to 110 patients the third day. And I had a headset. First I was doing this, and then I had a headset, and I from 7 a.m. to 7 p.m., we would just book people to be picked up. And we had 250 FEMA ambulances around the city, and we would just go get this patient, go get this patient. It was literally like when you see those cartoons where the guys run in, they take the patient off the stretcher and they run out. I mean, that's literally what we were doing. There was no signing out. It was a discharge summary, a MAR, an MAR, 5 days of medication, and make sure the patient has a tracking bracelet on. It was a way for us to tell where the patients were coming from, and then potentially where they would be going to. Called e-fines is what the Department of Health calls it. So those 5 things, and we're coming to get your patient. And overnight, between 7 o'clock at night and 7 o'clock in the morning, they would just like move all these patients. And by the next morning, we were full of those patients, and we started filling them back in. And this basically went on 12 hours a day for, it was a good 2 weeks that we were trying to fill the place up, also getting people to go. And also seeing the change in medicine. When we first started, there was no hydroxychloroquine and Z-Pak people were on. And within a couple of days, every patient was coming on hydroxychloroquine and Z-Pak. And initially, people were just on 2 liters of oxygen. The next thing you know, they were on non-rebreathers, because to decompress the hospitals, we had to start taking more and more critically ill patients. And as we started taking more and more critically ill patients, it was now we were opening up our intensive care units, which initially we weren't using intensive care units at all. So then the patient's family started calling. And then it was we had a whole area where they needed to know, could you please talk to the doctor downstairs and find out what's going on so we can, tell the patient's family, because nobody had family with them. Nobody had cell phones on them. One day, my son and daughter were back from college. They're both interested in medicine, and they're both EMTs. And I said to the Department of Health people that I was there with, and we all became very friendly. I said, listen, I have 2 young kids, healthy kids, and they can come in and they can help out. They can go downstairs and help out. So someone had donated a box of iPhones and toys and books and clothing. I mean, imagine these people were coming from the hospital. Their clothing was being left in the hospital, and here they were now, and they had no clothing except for a hospital gown. And there really weren't any new hospital gowns, because the Army initially forgot, oh, gee, we should order hospital gowns for patients. There were some things they forgot to get. So we sent them, downstairs. So they got to experience what Mom was experiencing, because I had gone down there at first, when I first got there, where there were no patients, and I went and I spoke with the people in the pharmacy, because the Army had set up a pharmacy. What kind of meds do you have here? So I know what to accept people with and what to tell them to make sure that they bring. And then just seeing what the cubicles were like, what they had in them, and talking to the nurses and seeing the whole process of donning the PPE. I mean, they had everything from you.
Thank you. And Ann Marie?
Yes.
Ann Marie, we're having some audio issues at times. I think we're hearing almost everything you're saying, and we're all very inspired by it. Thank you for your dedication, your sacrifice. Just one follow-up question.
Do you have the pictures? Did you want to see the pictures?
No, I think maybe towards the end. We're going to move on to Dr. Bremer pretty soon. But my one question is, you relieve chronic pain and chronic suffering all the time. But how did it feel to change gears to relieving acute suffering?
I don't, you know, you just do what you needed to do at the time. I would come back after a whole day there, and I would see patients from 7:30 to 11 o'clock at night, televisits, to take care of my own patients who had issues, who needed medications refilled, etc. And they were equally as important, but it just wasn't as emergent, and it wasn't as urgent. And in seeing, as we all did, the urgency of the situation happening, I think you just turn it back on. You know, as Dr. Mina said, you're just doing nights. You're
Sure.
and
I
you
think
feel young.
she has
Yeah,
audio issues.
there's some audio issues going on. Yeah.
Let's
Volume was
continue.
fine?
Tim. Yeah, let's continue. Tim, can you go ahead?
Okay.
Yeah, you know, so Ann Marie, thank you so much. That was really I can't imagine myself in your situation, and so thank you so much for that. I was really inspired listening to you. I just want to shift gears for a moment. At the New York Society meeting about 6 years ago or so, I met a young man named Nick Bremer, who was a naval physician, a patriot. And so when Nick came to join me in West Virginia, about I guess about February, March, I started talking to my friends in Italy, my friends in Spain, and much like Ann Marie, I knew something bad was coming. And as you know, New York became the epicenter. And Dr. Bremer felt a calling to leave our chronic pain practice in West Virginia, where we weren't very busy because all procedures were basically shut down, to go and really give back. We're to Bellevue, where he had trained. So Nick has inspired a lot of people in West Virginia. And Nick, we'd like to hear a little bit about what it's like to go from a simple country private practice in West Virginia to an intense life and death situation in New York City. Can you tell us what you've experienced there?
Go ahead, Tim. Your microphone is off.
Nick, your microphone's off, sir. You're muted, I think. So there's a little microphone beside your name. It should be green. It might be red.
Yeah, he is green on this end. We cannot hear you, Nick.
Okay, I think what we'll do, Nick, we're gonna have Michelle call you and try to get that fixed while we'll go into the next person.
As the next should be Ajit Roy. Is he around? Let's if he's back, we can ask him to join.
Nick, hold on, Nick, are you there? Can you say something, Nick? Yeah, we're still somewhat muted, I think.
Yep. We'll go to Dr.
Okay.
Brian, why don't you go ahead and introduce Ajit? Yeah.
Yeah, Nick, we'll be back. We'll be back to you.
Yeah.
So is Ajit here?
Yeah. Brian,
Ryan?
go ahead. Yeah.
Great. Brian, you want to introduce him?
So this is another anesthesia pain guy who is put down the needle for the intubating equipment. Is he here on the? I don't see him on the panel. Dr. Rai, are you here?
There you go.
Hey guys, I got called into an emergency. How are you?
Very well. Thanks for joining us.
Thank you for having me. First of all, it's a huge honor to be sharing this experience with so many dedicated colleagues. Yeah, I'm practicing in California. I did my training at Cornell Medical Center with Neil Mehta, Dr. Dewan's former program as well. I'm doing primarily chronic pain, inpatient chronic pain, acute pain, and anesthesia. I finished in July of 2019. And after that, I did Doctors Without Borders for 2 to 3 months in the Middle East, where I helped build a chronic pain program for war-wounded refugees from Syria, Iraq, Palestine, and Yemen. After that, I began practice in California, and then my colleagues here in New York City began telling me about the horrors that they were experiencing here, and I knew I couldn't really wait. So I left my practice in California. My colleagues there were very understanding, and I got emergency credentialing at my former hospital, New York Presbyterian, where I was been staffing COVID intensive care units, and I also got emergency credentialing at a handful of hospitals in the Bronx, which is where I am currently. You know, I think one of the things that's so inspiring is how the medical community all over the world has really come together to fight this battle together. I mean, so much of the research in treating COVID is coming from anesthesiologists from all over the world, from Italy, from Portugal. So, you know, although this has been very devastating for our country, I think one uplifting aspect of this entire process is just seeing how doctors have been so resourceful, and how we've been using our network to collaborate. Yeah.
Brian, do you have a question for Ajit?
No, I just think it's amazing that, you know, people coming from all over the country coming back to their roots here in New York where they trained and giving back. And I'm extremely humbled by your guys' bravery and, you know, dedication to medicine.
Actually, I'd like to ask you a question, actually, if I could. So, you know, you were over in, I have some good friends from Syria. So you're in Syria with a battle wounded, and then you're in a COVID unit. What's the similarities? Is there anything similar
Believe
about
it or
those
not,
situations?
Yeah, so I took care of a lot of Syrian refugees who had some pretty devastating war injuries. And I think the similarity that I saw was the fact that resource depletion there is very common. And here also there's a lot of resource depletion. And, you know, I'm very into doing humanitarian aid, but never in a million years did I think I would be doing humanitarian aid in a resource deplete region that is New York City. Like,
Wow.
that was just mind blowing to me. But yeah, you know, when I packed my bags and booked a one-way ticket to New York, I didn't tell my parents. So that was kind of a fun conversation when they found out that I had kind of blown into the inferno.
Wow.
But they understood that, you know, medicine for a lot of us is a calling, and I had to be here for the city.
Yeah, amazing story, you know, all the places you've been. So you have to write a book someday. So thanks for joining us tonight. We appreciate you, and I'm inspired by you. And I'm inspired by Nick Bremer too. So Nick, you're back. Can you talk about what it's like to go to New York City and back to your old training grounds, Nick?
Sure. Can everyone hear me now? Okay,
Hear you
great.
quite well, yes, sir.
All right.
You know,
So firstly, I want to thank Dr. Dewan and Dr. Chapman for the kind invitation.
Yeah, now I'm just going to
entire NYSIPP family, and I thank Tim for starting up this charity, so you know, so we can help others in our process here. My story is fairly straightforward. It really started with an interest in what was going on in Manhattan and New York City. I was watching the COVID cases on the Johns Hopkins website for seemingly months, and the worldometer go up and up. And this led to discussions with my other friends in anesthesiology as well as critical care. There seemed to be a need for physicians trained in airway management, central access, ventilator management, critical care, proning, just about everything you can imagine in the hospital, to include the OR. But I didn't really know how to help, or really what to do. I started getting emails from, you know, because I have a New York state license, from, you know, Governor Cuomo and all these other kind of entities, you know, asking for you to sign up as a volunteer. My old program director, actually Dr. Wajda, sent an email out, you know, asking for people to come. in basically early April, things were in crisis mode, both on the news, but also in reality. Kind of confirmed this with, friends here, boots on the ground. So I decided it was time to pull the trigger. I got approval from my wife, and she basically said I could come without delay. And so I made my way up here, actually, to where I trained in anesthesiology. I was instantly impressed with how well HHC managed this crisis. I actually had the opportunity to meet Bill Hicks, who's the CEO of Bellevue, and talk to him in detail about the disaster planning. And I just have nothing but amazing things to say about the people here, including Sudhir Jain, who runs the anesthesia department, ICU physicians, David Roccaforte, Caitlin Guo, Ken Sutton, and everyone from the other from the pulmonary critical care side as well. Everyone just really works together, NICU, SICU, MICU, CCU, and all the other ICUs you can imagine. So it's really great to see. Everyone's here for, one mission, and that's to help the COVID patients, and that's about it. I didn't see the virus itself as a major issue as far as exposure for me, partly because of my prior, Navy experiences. There's this thing called operational risk management, where you can accept a degree of risk in order to kind of achieve the mission, and that's exactly what we kind of are doing here. So personally, I just think we're just doing what we're all supposed to do, what we all are kind of trained to do, and day in and day out, that's what we do. So anyway, that's my quick story, and
Nick, let me ask you one follow-up question. That was a great, obviously you're inspiring to all of us, and great work you're doing. But here's a question for you. The news is so distressing. If you watch CNN and Fox, you jump off a bridge probably. It's very depressing. Tell us a victory. What have you seen that inspired you since you've been in there? What made you happy? Tell me about a victory you've seen.
So there are victories. There are victories every day. I could tell you about a story today. Even we're getting, kind of middle-aged, very kind woman. She's extubated. Her family was at the bedside today. She's going to be moved out of the unit here pretty soon, and that's a win. Those wins are hard to come by. They're not few and far between, but they certainly don't happen every single day on every unit. So there are other wins. There was a lady who gave birth, had COVID as well, ended up with respiratory distress, and both baby and mother ended up doing fine. So that's another win.
Oh, that's great. That's great. We need to hear those things. That's wonderful, Nick. Thank you so much. And we're praying for your safety up there. And I'll give it back to Sudhir. Sudhir.
Yeah, Nick, thank you so much. Your services is really priceless. And we have few minutes for the backup if Ann Marie is still there.
Yes. Can you hear me?
Yes. Yeah, go ahead. You have a couple of slides you wanted to finish.
Can you hear me?
Yes, we can. We have
okay,
3 minutes. Yeah, we have 3 minutes for you if you want to finish your slides. Yeah.
Okay. No, I just, these were a few of the pictures I took. Can you hear me okay now?
Yes.
Okay. These are a few of the pictures that I took and you put into a collage. This is the Javits Center on the left. This was the entrance on the right. Oh, if you go back to the previous picture. Okay, that's fine. This was a board that they had up. Okay, this is on the right is the entranceway where you waited in line and to get in and then go upstairs. In the center is just a picture of this is how we listed the patients, where they were coming from, and the way that we all communicated in there. It was a very a quick sheet that we threw together, a smart sheet, to be able to track people, to let FEMA know to go get an ambulance. And when docs called up, if we needed to speak with them, we had their name of who called. You can see how a lot of the people on the list were Elmhurst Hospital. That was our biggest, one of the biggest feeder hospitals, as you heard about in the news. And then the next slide is down in the right-hand corner. Those were the 5 pretty much people I was working with from the National Health Service and the Army and the Department of Health. And the center is the list of patients. If you could, zoom in on that, you'll see that the dates of April 6th up until right before Easter were, the busiest. But this is how we would track how many people we had in. The Army's big into tracking how many people were in, how many people were going. And we never reached the numbers we thought we were going to reach, thank goodness. Left on Friday and discharged the last patient. Everything is cleaned and sterilized and left in place for the fall. And hopefully that won't happen. But it was called Operation Gotham. And that's what'll come back.
That's very good. I mean, those people who don't know, the Javits Center, it's a center for car, showroom for cars and boats, and it was turned into COVID hospital. And Ann Marie was there. It's such a wonderful situation, and I cannot thank you enough, Ann Marie, your services. Again, we will have some time at the back. We're gonna move to next panel, and just stand by if somebody has any questions. Okay, so next speaker is going to be Mary Carter, and unfortunately her camera is not working, so we're gonna be hearing Mary Carter on audio. Brian Durkin.
All right. So Mary is a very close friend of mine, and has been a pain nurse practitioner probably longer than anybody on Long Island. She's the president of the Long Island Pain Nurses Association. She is also a Yankee fan, like Dr. Deere. Me being a Met fan, it's all right. Well, we're outnumbered right now. And Mary has been working at North Shore Manhasset Hospital, which is one of the big Northwell hospitals in Nassau County, and was really on the pain service, taking care of chronic pain patients in the hospital for the last year or so, and was called upon by the hospital to put down the pain management badge and go back to bedside nurse practitionering, if that's a word. So Mary, why don't you tell us
a word now.
about what you've been dealing with for the last 6 or 7 weeks.
Absolutely. Everybody can hear me?
You sound great.
Yep.
Okay. First of all, kudos, Dr. Deere, Yankee hat. I'm very happy about that. Just my background, I am an adult nurse practitioner, and I'm board certified in pain management, and I've been doing pain management for about the past 23 years as a nurse practitioner. And I did work with the anesthesia group out of Northwell for many years, over 18 years, and I left them for a different job, and I came back as a hospital employee. I actually started a chronic pain service for Northwell in Manhasset. And I only came into this job in June last year, and things were going along swimmingly. And then the beginning of this year, I, like Dr. Stillwell was saying before, I knew something was up and something was not going to be right about what was going on. March, we started picking up a lot of COVID cases. They were isolated to one ICU. It didn't matter if the patient was intubated or not. They went to one ICU. So, of course, I ran to Costco and I stocked up on toilet paper as well. But as the hospital started admitting more and more COVID patients, the writing was on the wall that the hospital was turning over to a total COVID hospital. And of probably over 800 beds, there were 2 units that remained non-COVID. One was the oncology unit that houses the bone marrow transplant unit, and the other was the neuroscience unit. So, of course, as my pain consults were tanking, I knew the writing was on the wall, and I was going to be deployed, as we call it. And sure I was. I was deployed by the Department of Medicine to take up COVID patients. And it was hard because not working medicine and working pain management for so long, I was freaking out about not even taking care of COVID patients, but of the simple things that nurse practitioners have to do at the bedside, like blood sugar control or chasing electrolytes or chasing coags. And I can say the only thing that saved me is the fact that I do teach in a graduate nursing program. So just by virtue of my teaching, I have kept on top of things. I found myself deployed with, we call them ACPs, Advanced Clinical Providers, which are NPs and PAs from all over, and especially outside the hospital, those that are hospital employees that are working in offices. So I've found myself working with a lot of orthopedic PAs, some nurse practitioners from pre-surgical testing, outside GI, outside plastic surgery. So these ACPs were more clueless than me, which was kind of scary. So I became kind of the leader of the unit. And the way the units are set up is they have the hospitalists covering the units, and the ACPs are there 24/7, really taking care of the patients with the nursing staff and the nursing assistants. So I'm used to working 13-hour shifts. My colleagues I was working with are going from 8 hours outpatient to 13-hour shifts inpatient, and not just working 6 shifts in 2 weeks, but expected to work 7 to 8 hours within 2 weeks, and also rotating to nights and weekends, which I can't tell you. I think the last time I worked a night shift was 25 years ago. I'm really dating myself here, but it's the truth, and the body just can't keep up with it. I'm kind of messed up when I work nights, but caring for the COVID patients, I got to tell you, Northwell was very generous with PPE and even the N95 masks. We never had a want for PPE. It was always there. As the hospital got worse and worse, they changed our auditorium. It's called the Rust Auditorium, beautiful auditorium. All the seats were taken out of it, and it was set up as an ICU. And then FEMA came and put tents up on the hospital grounds in the parking lots that were now empty. And the refrigerator trucks started rolling in because we just didn't have the room, multiple refrigerator trucks on campus. And I got to tell you, at first, getting used to the flow of taking care of patients medically, I did kid around and I told Dr. Durkin that I felt like an intern, doing the scut list and chasing labs and stuff. But I think donning and doffing the PPE was the hardest thing for me. Just before you go into a room, coming out every time, it was just a job in itself to don and doff, which became second nature by the second or third week. Very, I guess, gratifying to become a cohesive unit with the other ACPs I was working with and even the hospitalists. And I have to say we were very blessed because we were deployed with the nursing staff from the palliative care unit at North Shore. And those nurses are fantastic. And they were, basically telling us everything that the patient needed. They're wonderfully smart with a lot of the death and dying stuff. I did take on a lot of the death and dying. I felt that was my place as the pain management person on the unit. I took care of a lot of the DNRs, DNIs. And I did help everybody. I gave everybody strict pain management lessons. I actually had an argument one night with a PST nurse practitioner who wanted to give a dyspneic and in pain DNR, DNI IV push dilaudid, and was really in a sweat over even ordering 0.2 milligrams. And I had to talk him down off the ledge and tell him that it's okay and we can actually order a milligram. It would do the patient no harm, would just do them good. But probably the hardest thing I've had to do in all of this is not only the codes and calling families to tell them that their loved one just coded. The worst was doing the death call. I'd never filled out a death certificate or pronounced anyone dead in my career. And now I can say I can do it pretty proficiently, but those phone calls are the worst. That's the hardest thing I had to do with this job. And I could tell you at this point, I am still deployed. I actually have a long weekend, but I'm back Monday, working days, thank the Lord. And that's about it. Very bizarre and awesome experience at the same time.
Well, Mary, we're grateful for your service, and we hope we can get things back to normal. You can get back to treating pain patients sooner than later. I'd just like to say,
because
yeah, go ahead.
I'm sorry, pain doesn't go away. It's I should put a little aside here that our service never quite closed down, and the other nurse practitioner I worked with was deployed as well. And one of our main covering hospital physicians, Dr. Robert Duarte, was actually, he's in the Army National Guard. He was actually at the Javits Center as well. He was deployed by Northwell and the Army National Guard to work at Javits. So when anyone wanted a pain consult in the hospital, everybody has my cell phone number, so they were calling me, and I would do on the phone consults because I couldn't leave my unit to go see the patient. So I'm kind of been doing 2 jobs for the past 4 to 5 weeks. So
All right.
never a dull moment in pain.
No, there's not. Well, thank you, Mary, and thanks for participating today.
Thank you for asking me. This is wonderful.
All right. So as we all know, this is a fundraiser, and anybody watching out there, if we could ask you to come up with a donation, we would greatly appreciate it. It's going to a great cause and helping these people that we have coming out and telling their stories today. So please, if you can find it in your wallet to come up with whatever you can, and we can help make a difference in some people's lives. Dr. Dewan?
Thank you, Brian. Thank you, Mary. This was wonderful. Now I have a pleasure to introduce the next speaker, who is my former colleague. She was my PA until she decided to go for to be PA for plastic surgery. So Erica Bartoloni, she is a PA for plastic surgery in Lenox Hill Hospital. And one day she was asked to go work on the COVID floor. So very interesting story. Erica is a wonderful, wonderful person to work with, and I'm very happy, very proud of her. I'm happy that she could join us today. Erica.
Thank you. Hi, everyone. Thank you so much for having me. When Dr. Dewan asked me to be a part of this, I immediately say yes because it's Dr. Dewan. But after learning about the cause and seeing who the other panelists are, I feel even more lucky and honored to be here today. So as Dr. Dewan said, I'm a physician assistant at Lenox Hill Hospital, currently for the Department of Plastic Surgery. About 2 months ago, the director of PAs requested a meeting with me and told me the hospital was planning to redeploy PAs from their specialties to either the ED, ICU, telemetry, or a regional medical floor to help with the anticipated wave of COVID cases. All the PAs were instructed to fill out a Excel sheet with our individual skills to best determine placement. So the next day, we got an email pretty quickly that the first 2 patients tested positive at Lenox. At this point, we were still doing elective surgeries, and when they had talked about this redeployment the day or a couple days before, it seemed more like a worst case scenario in the future if they run short. But sure enough, the very next week, I was called and told I was officially redeployed to a new regional unit they created. So I was certainly nervous because this came faster than I was ready for. But since the majority and since the patients that I usually deal with in plastic surgery are usually pretty healthy, I don't often deal with sick, medically complex patients, let alone ones with the new virus we knew very little about at this time. They called the unit I was going to CAP, or COVID awaiting placement, meaning the patients were awaiting a negative test result either to be discharged to a subacute rehab or they needed to be approved for home care. So some of them were stable and truly ready to go, but as anyone who's worked in a COVID unit will tell you, a patient can really be fine one day and then go the other way very quickly. So a couple of days later, on top of that, it was decided that this was also going to be the DNR and DNI patients, and their goals of care were going to be comfort measures only. So quickly, our supervisor sent out an email reviewing how to pronounce someone dead, calling family with the news, what should really be said, and signing death certificates, which I've never really had to do before. I've worked for PAs 9 years, and the first 5 were in pain management and then in surgery, so I was definitely no stranger to ordering IV Dilaudid and morphine, but having to put the PRN reason as air hunger was definitely a first for me. And to think that less than a week ago, I was doing a tummy tuck case, and now I'm in a unit that was created less than 48 hours ago full of coronavirus patients felt like an alternate reality. and was really a major adjustment for me. First week was really tough. I saw things that I never see, and I was doing things I never thought I'd be doing. I think the hardest part for me was seeing that a lot of these patients were no different than myself or a close family member. Some had complex medical histories, but a lot didn't. And the problems that they were having weren't just respiratory. A lot were in renal failure. And from being in a hypercoagulable state, a lot of them had embolic strokes or pulmonary embolism. I really felt like I was back to being a PA student on my first day of rotation. I was happy to help, but knew a lot of this was out of my league, and I had a lot of learning to do. The PAs and nurses I worked with the first week were also mostly from surgical subspecialties like me, so we were all pretty out of our comfort zones. We didn't have any medicine residents on our unit, and since it was a brand new floor, there wasn't much structure. So the PAs and I did our best to pull together, with the help of one of the hospitalists, to create a workflow, like a regular rounding time and some unit-specific protocols, since we had a very unique group of patients there. The hospitalists that I met and worked with along the way were so smart and the most patient physicians I've ever worked with. After rounds, every single one always made a point to thank us all for being here and thank us for our flexibility during this difficult time. And they always stressed how helpful it is to have us here. And while I partly think they were all just really nice and being nice to us, I can tell it was genuine, and it really motivated us more than I'm sure they knew. But as stressed I was in moments during that first week, I never felt unsupported. I really think Northwell did a great job. Every day, especially the first week, we either had a call or in-person meeting discussing how everything's going, what's working well, what's not working well, how we can make things better. So the communication was really amazing. The employees also had access to a tracking board that showed the number of COVID patients admitted, pending COVID tests, total patients, along with the whole curve, so we can kind of see where we're at. So between that and the constant communication, I never felt in the dark about anything. I was always impressed how everyone stayed so calm throughout, and there was always a plan in place for the next steps ahead. It was really incredible to see how innovative we've all become. Our plastic surgery office is on the 3rd floor of the hospital, and within just a few days, it transformed into a brand new ICU. Things continue to change and evolve every day, but after the first week or two, I started to feel like I had a little bit more of a grasp on things, as much as I could have at that time. And by the second week, they actually had me training other ACPs or advanced care providers, because a lot of them were from outpatient settings and didn't know how the hospital works or the EMR that we use. So I went from kind of being thrown in the first week to now training people. And I'm really not sure, but I took it a little bit as a compliment. They also asked me after a few weeks to help open a new unit at Lenox Hill Greenwich Village, which was going to be similar to that. And it helped decompress the main hospital and add to our bed capacity. So the nice thing about these couple of units, we did get to see some of the discharges. So that was really motivating to see patients that had been on vents and got so much better and were able to go home. So from there, I went on to 2 additional regional units and worked with medicine residents, which was another great experience. I continued to learn a lot from them, and it was nice getting to know some of the people that were usually at the other ends of the pages from medicine and from when I was working in surgery. When I first got called into that meeting, I felt like I was probably a last resort provider, being from plastics, but from day one, everyone in these units made me feel valued and necessary. I feel like I even surprised myself in certain ways. I learned so much in the past 2 months and met so many amazing healthcare workers along the way in the 4 units I worked in. Since most of the providers I worked with were from so many specialties, it was amazing to see everyone's different strengths and see them contribute something different to the team and see each grow as a provider in such a short time. Knowing I had this strong system of colleagues at Lenox and friends in other hospitals to vent to, get advice from, and exchange stories with was something I found to be the most helpful during challenging time. Even friends or family outside of medicine that I may not even speak to or see often were reaching out regularly just to check in. And then, of course, I think everyone's favorite in healthcare right now is that 7 p.m. citywide clap. It's really moving, and it's really nice at the end of the shift to hear that. So it's been an intense adventure in a short time. I was definitely a bit nervous at first, not sure what was going to happen next for any of us. But after some time, I started to feel a little bit more confident that I was exactly where I was supposed to be, and I felt ready for the challenge. Reflecting on the past couple weeks, months, I'm really proud of what all the colleagues that I've worked with and I have accomplished together, and definitely humbled by some of the providers I had the privilege of meeting and working with. The camaraderie really feels the strongest it's ever been across all the departments and roles in the hospital. And I think that's something that we'll all really benefit from going forward. So we're still in the midst of fighting this, but I think we've all shown really great resilience and learned a lot. So I did find out that this will be my last week. So next week I will go back to plastics, but if things change, I'm ready if needed.
That's so nice of you, Erica. Knowing you personally, your dedication, your work ethics, and I know you so well. I know your parents, and we are all so proud of you. I have just one question for you. How did everybody in your family and your friends handle it? Because they are all worried about you getting infected or putting yourself in the risk. How did you handle it?
Yeah, I mean, everyone's worried about me, but I mean, like Mary was saying before, I never felt unprotected. There was always PPE. That was always their main concern. Even little things to minimize exposure if it meant going into the room less or kind of doing it at the same time as someone else, communicating with the nurse that had that patient too. So I never really felt unprotected, and I just assured them of that.
That's very kind, very nice. Tim, do you have any question for Erica? Tim, do you have any question for Erica?
So Erica, I think, I've worked with PAs and nurse practitioners for many years, and what I find is, many times it's your decision making that occurs immediately. You really don't have time sometimes to collaborate. Did you ever feel like you were overwhelmed by that, or did it come pretty natural to you?
The first week was a little bit stressful because, we started off saying, okay, everyone's stable and pretty ready to go home on this floor. And then the first week, like someone had a rapid response. I was like, oh, wow, they're stable-ish. So it was also the habit too of remembering, like, we're so used to just running into a room when, like, just last week we had a code blue and we all just went to run into the room and the nurse was like, stop. I was like, right, we're just so used to just going in and like starting chest compressions and to remember, like, oh, right, N95, gown, like all so it was definitely something to get used to. But we definitely, the first week I think was the toughest as far as not having as much structure and support. But after that, we had a really nice system of someone could always contact, someone was there. So yeah, there was a lot, but we kind of started to get the hang of it.
So I would just compliment Sudhir because you work with Sudhir, and I find that my PAs and my nurse practitioners we become such a great team, and you really get the decision-making process of those you work with. So probably I would imagine working with Sudhir in the past and your current positions has made you very independent and very rapid in your decision-making. So I applaud you for that, and thanks for all the things you've done to help those in New York. Very impressive.
First job, so Dr. Dewan fostered that.
Can't beat that for sure.
Yeah, Brian, go ahead for yeah.
All right, our next speaker is Cindy Corcoran. She's with no doubt the greatest fire department in the country, I would say, fire department in New York. She is an EMS lieutenant paramedic, and I've always said that's got to be one of the toughest jobs to do is be an EMT in New York City, up and down 4 or 5 flights, carrying people out. So it's a wonder. That's just a regular day. Now, on top of it, with this pandemic, she really, I'm sure, has some stories to tell. So, Cindy, it's all yours.
First and foremost, I'd like to say thank you for allowing me to participate in this. I think this is a wonderful cause. And I want to thank all of you for all of your hard work that you guys are doing. We appreciate it on our end because we are there pre-hospitally, so it's a completely different environment. It's uncontrolled.
You know, we don't know what to expect when we walk in, what family members are going to be, you know, yelling at us to help their loved ones. It's madness. It gets a little crazy sometimes, especially with this whole thing going on, because when we arrive on scene, now we have to gown up. We have to put our, you know, don our PPE. So the family members screaming at the door, hurry up, come on, my family member's not breathing, or whatever the case may be. And we have to protect ourselves, because if we go down, who's going to come and help you? You know, and unfortunately, the way that it went, I mean, I also knew about this before it hit the media. My husband is a Port Authority police officer, and he was telling me there's flights coming in from China, and they're screening all these flights, and, you know, they're quarantining people. And so I kind of had an idea what was happening. And being that I work in Queens, JFK is minutes away. And we started seeing a lot of these patients in Queens because they were coming in. They were family members of people that were traveling out of the country. So it was a little hectic in the beginning, and it was day by day, things were changing. Our protocols were changing. You know, 1 minute, every cardiac arrest now is a fever cough. So now we have to don all of our PPE for every fever, you know, cough arrest. And then every job started coming over as a fever and cough. So now we have to don our PPE for everything. And N95 masks were scarce. When we found out that this was going on, we actually locked up our N95 masks in another room, because every other station in Queens, they were disappearing. People were taking them, they were hoarding them for themselves. So it was a little scary at that point, because we didn't have enough PPE for our own members to protect themselves going into these jobs. So that was one thing that was a problem. And then also the people in my station, about a quarter of the people from my station, I have 100 employees at my station, became sick. And they were calling and telling me that they had flu-like symptoms and they think that it's just the flu. I said, I think you need to go call and get tested. So we had a hotline that we'd have to call. And then they started doing surveys. Every day we'd have to take a survey in the beginning of our tour and at the end of our tour, in order to find out if, you know, we had symptoms. So it was very mentally exhausting, you know. And being that my husband was also quarantined for 14 days because he was exposed to a positive COVID at work. So I have 3 children. My daughter's a type 1 diabetic. So I have concerns of me bringing it home to my household and him also. And there's nothing we can do, because now everyone's home. Everyone's homeschooling. You know, my parents, I didn't see my parents for 2 months, you know, because I was afraid to transmit something that I had to them. I ended up getting tested also, and I was negative, but the next step now is the antibody test. So now we're all getting to this antibody test. So now, speaking about what I saw on the street, we were seeing patients with O2 stats in the 30s, still mentating. It was insane. You know, essential cyanosis, and then 1 minute they were talking, the next minute now they're in cardiac arrest. You know, it was pretty insane. It was intense. We were pronouncing people, like 10 patients. I had 10 cardiac arrests in one day, and pretty much every patient was an 83, which is a DOA. You know, we would go there, and we had a new protocol where we would work the patient up, first line meds, we'd give epi, and then after 20 minutes, if there was no change, then we were able to pronounce the patient and then call out telemetry and go through that route. So that was another thing that was changed. We actually went back to normal now, but so we would work patients up, and if it was BLS, anybody could pronounce the patient. Normally, it's, you know, BLS can pronounce ALS, lieutenant, for DOA, obvious death. So it'd be rigor mortis, you know, dependent lividity, stuff like that, you're able to pronounce on scene. But if the patient is warm and they're viable, we'd have to do CPR if there's no DNR or DNI or whatever the case may be. So now we'd work the patient up 20 minutes. If there was no shock, we would then pronounce. And telling family members that their loved one is dead, it never gets easy. It's one of the worst things that you have to do. But when you're going to the same residence and telling them that their mother is dead and then their father, who you pronounced 2 days prior, is also dead, it's pretty terrible. So like I said, emotionally, this has been a roller coaster. And I keep telling my members that, you know, it might not hit you tomorrow or a week from now, but in a year or two, this can come back, you know, and it can affect you and you don't realize it. But that's why we always talk to each other. And I feel like speaking to your peers about your experiences is the best way to cope with something like this. You know, we've never seen numbers like this before. The highest call volume that we had was 7,111 calls in one day. Normally, it's around 4,000 range. And that was like the end of March, early April. It was pretty intense. So
That's wonderful, Cindy. I have not been more moved for quite some time over the stories that I'm hearing. And one thing that you mentioned, Cindy, that I really resonated with me. When I was in medical school, all the medical students rotated through the emergency medical services overnight in Newark, New Jersey. And one common theme to that was that we all found it very difficult to cope as to what you guys walk into on a daily basis. How do you cope with what's happening around you at this great volume and the great death around you? What kept you moving and staying strong?
well, my drive is to help other people. That's the biggest reason why. So I'd go to work every day and hopefully, you know, we'd be able to help somebody. I mean, honestly, we only got ROSC twice within the month. You know, most of the time people were dying, but we got ROSC. But I'm not sure what the outcome was after that because, you know, honestly, I wasn't going into the hospital to check on the patient right now. As far as, you know, like I said, there's limited PPE and I don't want to minimize my exposure. So I wouldn't go, but normally I would go check on the patient and find out what their outcome was and see if anything happened. But I'm pretty sure that the outcome probably wasn't good because they were down for more than 10 minutes. So.
Thank you, Cindy. Thank you for that demonstration of true inner strength that we can all take inspiration from.
Cindy, I think that was pretty amazing. I grew up with a bunch of young people who became paramedics. So to hear your story on the front lines is something we don't often think about. So it's really touching. Dr. Dewan, you were saying?
No, I just had a very small question for Cindy. You always have that kind of stress, and as you said, from 1,000 calls to 7,000 calls. How did you physically and emotionally handle that?
It was very difficult. Like I said, emotionally, it was draining. Every day I would come home, and then on top of all of this stuff going on, my colleagues were becoming ill, you know, going into the ICU on respirators. So, you know, and passing away. We lost several members to COVID as well. So it was mentally stressful and exhausting, but the only way that I could say that I was able to cope with it was because of my peers and speaking to the members at my station and their experiences and seeing their strength and how much that they're working, you know. I mean, I was there to help them as well. So.
Unbelievable.
So,
yeah, go ahead, Tim.
I was going to go. No, go ahead. I was going to go ahead and introduce Anna next. Unless you have another question for Cindy.
No, I was just going to say it's unbelievable, and we salute your services, your hard work, and your dedication.
Thank you very much.
Absolutely. And so, you know, having been part of a lot of emergencies in my career, we always appreciate y'all. Anna actually is our next panelist, and I think our last panelist, I believe, if I'm not mistaken.
Yes.
Anna actually works in spine surgery as a PA at Columbia University. Before that, she worked at the Spine and Pain Institute of New York for several years in the pain community. So, and then recently, you've gone from pain to spine surgery to COVID. And I know you've been doing COVID for the last few months. So we'd like to hear about your transition through all those things and what you've learned the last 2 months and what you see going forward.
Sure. Thank you, Dr. Deere. First of all, I would like to thank Dr. Dewan and Dr. Chapman for inviting me to speak today. As you mentioned, yes, I've been working as a surgical PA, and for the past 3 years, I've been taking care of very sick patients with very complicated spine deformities who commonly have complications, and we're so used to see cardiopulmonary complications, post-surgical complications, patients with PE, ARDS, patients who require dialysis. And when we were informed about upcoming epidemic and possibility of switching to ICU team, we as a surgical PAs felt ready. We felt like we can do it. NYP provided an extensive training, critical care training for non-critical providers, and we did our job going through online training, learning how to handle ventilators and very sick patients. And when it started, when we started getting more and more COVID patients, which was the end of March, very quickly we have realized that they are sicker than we think. And one thing that we were definitely not trained for and definitely not ready for were the amount of dying patients. And that was definitely the most challenging part of COVID crisis. So my first night in ICU, I was assigned to take care of a patient who was 55-year-old female. She was admitted to ED around 5-6 p.m. and immediately intubated. She came to intensive care unit and out around 8 p.m. I had to call family to get consent for A-line, central line, VASCAF. That became like a standard of care for all the ICU patients. So you get a family on the phone and they are scared. They are very emotional. They ask you how their family member is doing. And you know, as a surgical PA who sees a lot of patients doing better, you give this positive message to the family. You tell them your family is going to be fine. We're doing our best. We're going to take care of them. Like we just need to do what's best for them. So it's a very positive first message, and then very quickly we started seeing those patients are not doing well, and within a very short period of time they're on max depressors, they're on a lot of medications to just keep them alive, and they're crushing and they're not doing well. So within 2-3 hours within my night shift, I have to call family again and discuss the code status and introduce them to something called DNR, which is not as a positive and good message to give them, and conversation. So that's the next conversation. A few hours later, we call family again to let them know their family member is most likely not going to make it. So at that point, we're bringing our phones and iPads into patients' rooms. A lot of families wanted to have the last conversation and see their family members. And then you become a part of a very personal conversation. So many times family members are thanking their parents for everything they got, they apologizing for a lot of things or saying things that they never had a chance to say, and you're part of it. So you cry, and the nurses are crying, attendings are crying, and it's very emotional time, and you can't even wipe your tears. They're just going to your N95 because you don't want to touch your face. So that has been my life for the last 2 months, and I've been seeing a lot of sick patients. I also had a chance to work in medicine department. I covered some night shifts there as well. So there were nights when I had 40 patients, and out of my 40 patients, 3 of them died. And like Erica and Mary were saying, the most challenging part was pronouncing them dead and signing death certificates. I actually, before this panel, I counted, I signed 21 death certificates within the last 2 months. I've been a PA for 10 years. I've never had a chance to be next to a dying patient, holding their hand, praying with them. They ask you to call their family, to say something to them, to tell them they love them. It's something that you can't teach medical providers. You can't get them ready for that when the pandemic is coming. So that was definitely very challenging. You know, our sign outs when we finish a night shift and give a sign out to the day team, we were just giving them information regarding patient O2 sats and how quickly they're going to die. So I would just say 2 of my patients are currently dying, like a few of them are about to die. Some patients like coded 3 or 4 times overnight, so there's a high chance they're going to die next shift. It's definitely something very challenging, emotional, something that was on our mind for a long time, but it was happening so fast. And we've had so many of those critically ill patients. We didn't have time to process that. We're taking it home, we're thinking about it. I had time when I couldn't sleep after my night shifts because I was still thinking about patients that lost their bottle, that didn't go home. So we've learned a lot during the crisis. We definitely got a lot of experience. We learned how to be a good member of a team member, how to count on others, and how to work together. The NYP did an amazing job with PPE and dividing us into teams and working together and with attendings and residents, but it was definitely very challenging and definitely a learning experience that we don't want to go through again.
It's quite the story, Anna, and we really appreciate hearing about it. And I would assume when you go back to your normal world of spine surgery, the stress
Yes.
there will be very easy for you to adapt to now. I mean, you've been through the war zone now, so you've been through a lot.
Yeah, we're talking about transitioning back to normal, and the plan is to slowly. New York is doing definitely much better. We're now seeing for the last week or two, we do see patients doing better, recovering, patients getting extubated. My first couple of weeks, we haven't seen anyone getting extubated. Almost all my patients actually, unfortunately, died. But the last 2 weeks have been much better for New York, and we're talking about restarting some spine surgeries on May 18th. It's a very slow transition. They want to be very careful. Actually, every single surgery has to be approved first by the hospital. There's a special team that has to approve all surgeries, spine surgeries, and then it has to go to the Department of Health, which has to approve it as well. So it's a complicated process, and it's not going to be an easy transition for sure.
Thank you, Anna.
Great.
We owe our progress to you and to people like you that made our current state possible. We're grateful as pain providers that have sort of been sidelined, but you guys are the heroes, and we're all thankful to you for that. And I'm going to ask the audience to recognize the sacrifice that's on clear display here by contributing to the Ironman and to the NYSIPP's effort to raise funds and help the causes around the New York State that are COVID related. So please take out your credit card, take out your checkbook, go online, whatever it takes to contribute what you can to this great sacrifice and heroism that has been before us as we listen to them today. Thank you. Thank you, everybody. It's truly moving.
Thank you.
I also wanted to just say one thing, that there are some of the speakers who are not just only Frontline team, but they also have donated to this cause. So I just cannot believe their sincerity and their work ethics, and I'm so honored and humbled to call these people my colleagues and my friends. So you are wonderful, and especially this young Erica and Anna, you guys haven't started your life yet, and you have faced such a horrible situation, crisis, and people will break down and get depressed, and you just fought through. So no words, no really words to thank you all. You guys are wonderful. So I don't have much time for the speakers, but panel, do you have any time, moderators? Any questions for the panel?
No, I I'd just like to say thanks to everyone, and I think that in the tough times, that's when we really learn about people. And everyone on the panel today has been so impressive, but we've learned what they have done for humanity. And even though we lost a lot of life so far, I think a lot of people were saved because of the efforts of people on this panel tonight. And I'm truly impressed. And I think you're all very brave. I have a daughter who's a nurse in Charlotte, North Carolina at the pediatric hospital, and she's seen her first few COVID patients there in pediatrics. So I think whoever's in the front line around the world and around the US, it's certainly inspirational to all of us. And those of you who've donated to the cause, that's another way to help. And again, that goes right to New York State on the ground for charities that work with people in COVID related issues like PPE, like helping those who are quarantined who need food and help, and like those who need other medical assistance. So thanks to all. And Dr. Dewan, thanks for your leadership. Again, Chapman, Chris Grebo, Brian Durkin, the whole Dr. Grotowski, Karina, the whole team, Ed Rubin. It's very impressive. So thank you for including me.
Thank you, Chris.
I would like to again make an appeal. There's been no greater sacrifice than sacrificing yourself and walking into the line of fire. We heard the spectrum today. I would like to thank our panelists, our speakers, and everybody that has signed on to get the full perspective or a better perspective to the COVID crisis. We pulled through this. Things are going to get better. It is a different world, but it's a better world than how it was just a couple of weeks ago. Thank you, everybody, and please contribute and do what we can. And we should all do what we can to help out the efforts through the Ironman Foundation. Have a good night, and hope to see you again soon.
Brian, do you have the final words?
I'd just like to say thanks to all the heroes that came and spent some time today with us to share their stories. And you guys are wonderful people and make me proud to be part of this medical community. And any last call for donations? I thank everybody that donated. Are we able to continue donations going forward, Dr. Dewan, Dr. Deere?
Yes, I think the next 2 days it will be still on, but I'll check with Sarah and Michelle, but I think it's still on.
This is Sarah. This is Sarah.
Sarah.
Hello, everyone.
Yes.
Yes, we wanted to say a huge thank you to everyone for their support of the IronAid COVID-19 Support Fund. Remember to please share the grant opportunity with health-related organizations who need support. That link is on the fundraising page, and the Jim Kelly drawing will be open until May 17th. So we'll continue to take donations all the way up until 6 p.m. on May 17th.
Oh, that's great. Yeah. So again, thank you all the panelists, all the frontline workers, caregivers, families. You all put your services before self, and we have no words, but we just say thank you. Thank you from bottom of our heart. And I also want to thank all the donors who made this fundraising webinar so successful. Our goal was around 15, and we went beyond. So I think you guys done a good job. So thank you, everybody. And I also would like to thank our organizers, Michelle and Sandra. As always, they have been very hardworking. This type of activities always have some heavy issues, but they are right there to fix it. So again, Michelle, Sandra, you guys are powerhouse. So thank you very much. And I think with that, we are over the time a little bit, and end of the webinar. And thank you, everybody. Have a good evening.
Good night.
Thank you.
Good night.
Good night.
Good night. Thanks.